doctor at Peace Health Medical Group, and my interest in the ACE study started really only last year. I was doing a talk on gambling disorder, and ran into some slides on the ACE study, and sort of one thing led to another, and you have today's talk. And so now the ACE study, or the Adverse Childhood Experience Study, and the underappreciated impact of childhood trauma, implications on primary care. A lot of what I talk today is aimed mainly at primary care behavioral health, and and how we do it. And so adverse childhood experiences are probably the most important thing that they didn't teach me in medical school. And it potentially could be more important than anything I learned in medical school. So the first two slides are going to provide sort of a background of a way to kind of think in the back of your mind about this talk as I'm giving it today. The first slide pictured here on the left is René Descartes, and René's he was the father of empiricism and reductionism, and he can be seen as the progenitor of the biomedical model of disease. And his cogito ergo sum, I think therefore I am, divided us into our consciousness and our body. And sort of the body kind of served the mind, and he did not separate us into our unconsciousness and consciousness. So he's sort of like the father of modern medicine. And so if you have that's sort of the Cartesian way. And then there was a famous neurologist, Charcot, who in the late 1800s was the first person to relate people with hysteria to people who've had traumas in their life. And Freud studied under Charcot, and he was the first person to relate the unconscious effects of childhood trauma to the diagnosis of hysteria. So that's sort of like an historical way to look at it. And ultimately, this is a talk about patient safety and empowerment. People who are traumatized, trauma patients, lack safety, trust, and agency. So how can we foster engagement in patients who feel hopeless, inadequate, unsafe, and have a natural tendency to mistrust? If patients lack agency, they are not empowered to take care of themselves. Now, agency is this sort of idea that you have control over your own life. And people who have experienced childhood trauma often don't have that idea anymore, that they can really manage their own life or they have any control. So if you talk about trauma-informed care services or trauma-informed primary care, our goal is to promote dignity, respect, trust, and safety in a therapeutic healing environment, design treatment, therapeutic relationships, and accommodations to meet patients' needs, reflect recovery and person-centered principles, reflect patient satisfaction, engagement, and empowerment through a therapeutic partnership. Now, David Shore of the Harvard School of Public Health wrote a book called Forces of Change, and he's the director of the Trust Initiative. He has pointed out in the past that trust improves medical outcomes and decreases the doctor-patient adversarial relationship. So today I'm going to review the ACE study initially, and then we're going to talk about different types of trauma. We're going to talk about the neurobiological underpinnings of trauma briefly, treatment approaches to trauma and co-occurring disorders. I'm going to give review some critiques of the DSM, and we'll talk about in general what trauma-informed care is. So the ACE study started in the 1980s. Vincent Felitti was a researcher at Kaiser Permanente's obesity clinic, and they did this sort of massive weight loss study in women, and he noted that there was a 50% dropout rate in women who met their weight loss goal. He was very confused by this. They lost like 80 pounds and was remarkable, and then they would just drop out of the study. So he went back and interviewed all 286 patients that dropped out and found that a majority of them had suffered from childhood sexual abuse. And in talking to them, he discovered they often ate to be invisible, i.e. not attractive, and to deal with difficult emotions, or both. And often they were not aware of why they were even eating. So he was really surprised. One of the reasons is, if you look at the main textbooks of psychiatry at the time, Kaplan and Sadek, there was only one paragraph in its 3,000 pages devoted to incest rates. And it quoted a 1955 study that basically said it happened in 1 in a million American families. So the general thought around that time was this was not a common thing, it was rare. Yet this researcher was finding that it's extremely common. So he actually went to a national conference on obesity in Atlanta and presented his findings. And in his, recalling what happened, he was actually mocked by some of the leaders of the conference for believing his patients. Believing that, the general feeling from some of these obesity conference leaders were that these patients are lying to make excuses for their poor life choices. So this is kind of how it was at some of the leading levels of, obesity research back in the 1980s. Luckily, he was a CDC scientist was there, and he introduced Dr. Felitti to Dr. Anda. And Dr. Anda is a epidemiologist at the CDC. And so they worked together, and they started this study that started in 1998 in San Diego. It's a collaborative study, the Adverse Child Experience Study, between Kaiser and the CDC. So they took 26,000 consecutive adults, and they screened them and came up with a cohort of 17,000 patients. These are middle-class patients from San Diego with good insurance. 80% of them were white and Hispanic, 10% Asian, 10% African American. Their average age was 57, 74% had attended college. And so what they did was, they asked all these people questions about their history between the ages of 0 and 18. And they asked them about, they picked 10 potential childhood traumatic events and asked them questions about verbal or emotional abuse, physical abuse, sexual abuse, emotional and physical neglect, divorce, witnessing domestic violence in the house, living with a problem drinker or alcoholic, having a household member that attempted suicide or that was mentally ill, or a household member that was incarcerated. So, this is the results they got on these patients, 17,000 patients. About 10% had, recalled emotional abuse, 28% physical abuse, 22% sexual abuse. Notice the dichotomy here, 28% of the women had recalled they were sexually abused, and 16% of the men. 15% emotional neglect, 10% physical neglect. 23% had suffered from divorce, 13% witnessed domestic violence, 27% lived with a drinker, 6% household member was depressed or attempted suicide, mentally ill. 17% had a household member that had been incarcerated for a period of time, not just jail for a few days, but like a year of prison. So what they did is then they took each answer of yes for each patient and gave each patient a score. That was their ACE score. And it's a proxy for their childhood trauma dose. And so the prevalence of having an ACE score of 0 in that population was 33%, 1 was 26%, 2 was 16%, 3 was 10%, 4 or more was 16%. So not only did they follow this population prospectively, and they still are, but they also looked at all their health issues and then just kind of compared it to their trauma score. So they noticed that as your ACE score or your trauma dose went up, it was proportionally related to your chance of having a BMI of greater than 35. they noticed that traumas tended to come in groups. That if you had a battered mother, there was a 95% chance that you'd have one more ACE score, 82% chance that you'd have two more, and so on. They noticed that your ACE score, your trauma dose, was proportional to your risk of being victimized as an adult. And you notice that women are victimized a lot more than men, but they're both pretty proportional. They noticed that HIV risk factors are related to your ACE score. And as you see, as the higher your score, going right here, your chances go up significantly. Look at have ever injected drugs. It is really about 0.1%, or less down here, and it goes up to 5% if you have an ACE score of 4 or more. So there's just a big relationship between what you experience in childhood and whether you grow up to, inject drugs or have an STD. Teen sexual behaviors. So we all worry about intercourse by the age of 18, teen pregnancy, teen paternity, and this too is sort of predicted very proportional to your ACE score. Lifetime history of depression. Notice how the women have definitely more depression than the men. And again, it's very proportional. ACE score greater than 4, over 50% chance of getting depression in your lifetime. So it follows, ACE score is related to the chances of you being on an antidepressant prescription. Virtually 100% of people had been on a prescription if their ACE score was greater than 5. Attempted suicide. Again, it goes from about 1% lifetime chance of attempting suicide to about 18% chance if your ACE score is greater than 4. Drug abuse, proportional. Ever addicted to drugs or had a drug problem. Ever injected drugs. Smoking and lung disease. Early smoking initiation, current smoking, COPD. So now these slides I'm using, I borrowed on SlideShare from Dr. Anda's SlideShare presentation in 2012. I credit it in the end. So these are his conclusions that it's just these red slides about the ACE study, that he concluded that adverse childhood experiences are endemic, they're highly interrelated, they have a cumulative stressor effect, their effects are biologically plausible, they have strong influences on adolescent and reproductive health, smoking, alcohol abuse, illicit drug abuse, sexual behavior, mental health, risk of re-victimization, stability of relationships, homelessness, and performance in the workplace. That basically they increase the risk of heart disease, lung disease, liver disease, suicide, injuries, HIV, and STDs. And that they're very common. Remember, this was a middle-class group they looked at with good insurance. They've done other studies like in Philadelphia, urban areas, and the numbers are much worse. They're a strong predictor of health risk and disease from adolescence to adulthood. And the combination of findings makes ACE one of the leading, if not the leading determinant of the health and social well-being of our nation. So now they just picked 10 things to ask about. Now there was a study in the archives of pediatric adolescent medicine that came out in 2012 where they asked, in addition to the 10 ACE questions relating to all these other things. And they did 2,000 kids between the age of 10 and 17. They did would rate the distress that the questions had, and compared to the ACE questions. And these other 7 issues could have probably made the cut for significant childhood traumas. Peer victimization, parents always arguing, property victimization by a non-sibling, bad accident or illness of loved one, below average grades, no friends, and exposure to community violence. So the idea is that you have an adverse child experience, and they theorize it's going to affect your normal neurodevelopment, which can lead to social, emotional, and cognitive impairments, which can lead to the adoption of high-risk behaviors, disease, disability, and social problems, and early death. So, how early of a death can an ACE score affect? Well, since they looked at this group prospectively, they have numbers on their life expectancy. So the ACE score of 0, 79 years in that group. If it's ACE score of 2, you lose 3 years, you live to about 76. ACE score of 3 to 5, you lose about 5.5 years, 73.5. But if your ACE score was greater or equal to 6, you lost about 20 years of your life on average in that group. So now I'm going to transition to types of trauma ways that we can think about trauma in the clinic. So you got your classic PTSD, which was originally a simple or single incident trauma. And there's in the DSM-5 a set of different categories. You have an exposure, you get intrusive symptoms of avoidance of areas that you were before, and negative alterations in mood, and marked alterations in arousal. And this was added to the DSM in 1980. And there's some limitations to the original diagnosis. It was originally mainly applicable to a single event. Now the DSM-5, they've changed it to, they've added an S from event to events to make it also count to more recurrent events. And they do make some changes in the diagnosis to try to make it more applicable to more people. When they originally made the diagnosis, it was formulated from specific trauma subjects, such as Vietnam veterans and rape victims. And some people had a critique that maybe there was a lot of other traumas out there and they could have looked a bit different if they'd studied different populations of trauma victims. It doesn't really address developmental issues with trauma in children, and it fails to address often the broader symptomatology of attachment, cognitive, and emotional dysregulation that occurs with complex repetitive traumas. Now, then there's complex or repetitive trauma. Now, these traumas are anything that recurs repeatedly over time, such as physical and sexual abuse and emotional abuse, physical and emotional neglect, being in a war, being a refugee, being a victim of human trafficking or captivity. And then there's developmental trauma. This is basically just recurrent trauma or complex trauma in children. And the idea is that it's worse since it's happening during times of development, which can have greater effects on the person. So if it happens between ages of 0 and 3, any kind of neglect or abuse, most harm can occur at that time because of the rapid development occurring in the child. Whereas it happens between 3 and 18, still a lot of neurodevelopment happening there. And these are all the sort of, when they look at the ACE study, it's basically developmental trauma because it happened during the years of 0 to 18 for all the recall. So the effects of trauma, this is from the National Child Traumatic Stress Network. There's a lot of different things that happen when you're abused as a child and are neglected as a child, and it affects your ability to attach to people, your emotional response, physical health, body and brain. Effects can cause dissociation, long-term behavior problems, cognition issues, self-concept issues, future orientation issues, and other long-term health consequences and economic impacts. So now, if you look at delayed emotional reactions, it might be easy to see a lot of these things in our adult patients and then label them as something else or miss the big picture, so to speak. So if you can have long-term symptoms of irritability and hostility, depression, mood swings, anxiety, fear of trauma recurrence, grief, chronic shame, feelings of vulnerability and emotional detachment. Often I might see patients like this and think, they might have chronic depression, type 2 bipolar, anxiety disorder, intermittent explosive disorder. There's a lot of overlap. And so sometimes you might be seeing some of the DSM diagnoses that you're familiar with, but kind of missing the big picture of, here's a person that suffered a lot of childhood trauma. The cardinal symptom of childhood trauma is emotional dysregulation. Now, alexithymia is an interesting word. It means difficulty identifying, expressing, and managing your emotions. Now, there's studies out there. There's a Finnish study that shows a strong relation of alexithymia with depression, and there are multiple studies out there that show relationships with fibromyalgia. Emotional, the idea, many studies out there by Lumley and Huber, and they're in the back here, kind of paint a picture of a theory that emotional dysregulation can lead to an increased negative affect, chronic sympathetic hyperarousal, and impaired immune status, and that can actually lead to physical symptoms of somatic disease and pain. Then you have delayed cognitive reactions that can happen, intrusive memories, self-blame, difficulty making decisions, magical thinking, generalization of triggers, suicidal thinking, changes of awareness. We could label these disorders, sometimes these symptoms as OCD or personality disorders. In children, you can see a lot of trouble thinking clearly, reasoning, or problem solving, difficulties planning ahead, deficits in language development, difficulties sustaining attention, learning difficulties that require support in academic environment. And, these could be labeled as ADD, ADHD, or learning disorder. So, delayed physical reactions, sleep problems, appetite and digestive problems, somatization, poor immune response, persistent fatigue, elevated cortisol levels, hyperarousal. And again, these could be labeled as insomnia, IBS, chronic fatigue, fibromyalgia, and chronic pain. So again, there's so much overlap when you have trauma. Sometimes we just look at the diagnostic criteria of something and say, I think it's this, but we might be missing the big picture. Delayed behavioral reactions, avoidance of events and reminders, social relationship disturbances, engagement in high-risk behaviors, alcohol and drug use. And again, these people might be labeled as social anxiety disorder, eating disorder, sex addiction, drug addiction, alcoholism. People develop also just normal, dysfunctional levels of normal behavior patterns. I like to look at things as sort of a codependent, counter-dependent behavior patterns to sort of get an essence of who I'm talking to in the clinic. And, these are normal behavior patterns. Everyone has a normal level of codependency and counterdependency. It's normal and healthy. But people who suffer childhood traumas might have dysfunctional levels of these behavior patterns. And so codependent behavior patterns get aggravated if you have a lot of childhood neglect. And basically, they have difficulty experiencing appropriate levels of self-esteem, difficulty setting boundaries with others, difficulty owning their own reality, knowing their feelings, understanding physical symptoms, difficulty meeting their own wants and needs, and difficulty experiencing and expressing their reality moderately. And counter-dependent behaviors tend to get worsened with abuse in childhood. And they are very uncomfortable with trusting other people. They push others away. They want to appear overly independent and strong and keep very busy. So a couple other traumas I'm going to touch on briefly. One is the idea of intergenerational trauma. Now, the classic way to transmit intergenerational trauma is through dysfunctional family transmission. That's how I got all mine. And so, so victims of complex childhood trauma become parents and pass on trauma to new generations. And they do this often because of just impaired parenting. They didn't get a good model for parenting when they were young, and they don't parent well when they're parents. And also note that if you're a sexual abuse victim, you're more likely to be a perpetrator as an adult or a victim as an adult. And so, there's a lot of ways in this family transmission that are, we all see it. I think Tolstoy talks about it in the beginning of Anna Karenina. And so, and then there's epigenetic transmission. So there was a study in biological psychiatry that came out in September 2016 that showed that proteins on stress genes have been detected as passed from traumatized Holocaust survivors to their children. And it's theorized that severely traumatized individuals can pass epigenetic changes that occur pre-conception to their offspring. And so that could affect, how your messenger RNA might work. And then there's historical trauma. So this started, the term came from the mental health communities helping the indigenous people of North America. And the 6 C's of historical trauma are colonial injury, collective experience, cumulative effects, cross-generational impacts, cultural genocide, and contemporary structural inequities. So I'd like to point out one of the big things that happened as far as cultural genocide to Native Americans in the United States and North America and in Canada were that they took children from their homes starting about 1880 and would put them in boarding schools to breed the native right out of them. So they were forced to speak English and dress American. They had to go to these schools, and this was actually very prominent all the way from 1880 to 1950 and wasn't actually made illegal until 1978. Think about that the next time you're wondering why the Native American community has such high levels of dysfunction. They were taken, and this, they returned the children over the summer and the parents didn't recognize them. Now imagine if that happened to your kid. It's just devastating. So now you can apply this to a lot of different populations of people. Descendants of slaves. Survivors of the Stalin, Stalin killed millions of people in World War II, like 25 million. And survivors of the Holocaust. There's another mini historical trauma that's happening in America right now. It doesn't have the same colonial and and doesn't maybe have as bad as the contemporary structural inequities as these examples. But if you look here, this is basically the mortality rates for various populations in the United States today. This is African Americans with a decreasing mortality rate. Here are Hispanics with a decreasing mortality rate. And these are Caucasians. And this is 1999 to present. We have a very going up mortality rate. It doesn't look much here. But if you break out people with a high school education or less who are white, there's a big uptick in their mortality rate. What's going on? Here's the rest of the world, and their mortality rates are dropping. But around 1996 here, you see this uptick in Caucasians. This was actually not discovered until late 2015. They did a lot of articles about it. What's going on? What happened in 1996? Anybody? The FDA approved OxyContin. And because of natural biases of African Americans and Hispanics to not trust institutions, and the well-documented biases of doctors not to prescribe Hispanics and African Americans narcotics because we think they're going to sell them, they were protected from it. And the Caucasians were not. At the same time, NAFTA and automation kind of caused job losses, and you mix that with and all that trauma of losing your job and your money, and mix that with wide availability of narcotics, you got yourself an historical trauma. Here's how everyone's dying now. This is overdoses in white non-Hispanics from age 45 to 54. Now again, all this stuff I showed you were the middle class. the middle age, 45 to 54, is where you're seeing this change. People in the prime of their life, my age. And then you have suicides heading up, chronic liver disease from hep C, lung cancer is getting better, we're doing a good job there. Diabetes is about the same. So we can look at things a bit differently when we step back and look at the big picture. So briefly, let's talk about biological underpinnings of trauma. This is probably the most fascinating part of the talk for me. There was a study in mice by Meany in 1999, and it suggested that early maltreatment can produce enduring negative effects on the brain. They created a mouse model for childhood trauma, and they showed a clear link between chronic stress and increased stress reactivity and poor regulation of stress reactivity in the HPA axis. So what did they see? They took mouse pups away from their mommy mouse for 3 hours repeatedly. And then they followed those mice to adulthood, and those mice had a proclivity for going to the cocaine and alcohol dispensers in their cages at a much higher level than mice that did not suffer from the separation. And they're like, why is that? So then they removed the mouse for 15 minutes, mouse pups, and put them right back to their mom. And those mice actually did better. They were less likely to lose alcohol or cocaine. And they got this incredible licking behavior from their mom after being gone for 15 minutes. Oh, I missed you. I love you. And they developed some resilience from a minor stress. But then they took the mouse pups away for 3 hours, but replaced them with another mouse. So the mom had something to do for those 3 hours. And then they switched them back. Those mice were normal. Which goes to show it's not the fact that the mice were taken away, but it was the behavior of the mother when they were returned after 3 hours of not having any baby. The mother mouse was very agitated, would sometimes trample the baby mouse or not recognize the baby mouse. It affects that attachment that occurs. So really, the childhood trauma was from the maternal behavior, because the baby's a blank slate. So what they found was there was increase in measurable corticotropin releasing factor, mRNA, in the hypothalamus that was sustained lifelong in neglected pups. A lifelong alteration in gene expression. So then they have a study from molecular psychiatry in 2009, and they took women and they did spinal taps on them, and then they did their ACE score, and they measured their oxytocin levels in their spinal fluid. And again, levels of oxytocin in the CSF were there in a dose-related fashion depending on the dose, severity, and duration of maltreatment in their childhood. And the strongest effect was the association with emotional abuse. So, and to summarize some of the neurobiology of trauma, in your brain you've got your frontal cortex that is all your higher level of thinking. Right behind your cortex you have your prefrontal cortex. Barry knows where that is. And so in there you have your watchtower. This is a subconscious area of your brain that is scanning for emotional and physical threats without your knowledge at all times. Because we are Homo sapiens, we are survivors, we have an incredible survival ability as a species. And that part of your brain talks to your limbic system, your hippocampus, which is the seat of emotions. Now, a memory in the hippocampus is not only attached to an image, it's not only attached to a sound or a smell, it's attached to a belief, it's attached to a feeling, and it's attached to a physiologic response. So if you detect something that reminds you of something bad that happened a long time ago, it could be situational, it could be a face, then you're going to tell your amygdala, which is your smoke detector system, let's start cranking out adrenaline now. let's start cranking out cortisol now. All this happens without your knowledge because it's an automatic, survival mechanism. It's very powerful. So you got your fight or flight system. So why don't zebras get PTSD? They're chased all the time by lions and have to survive. Why aren't they having PTSD? So if you look at an animal on an animal network and it's getting chased by a lion and gets away, a lot of these animals have mechanisms where they shake really hard all their muscles and they download all that adrenaline out of their system. That's like the equivalent of a really good cry. Okay? So children who are being abused by parents and it's kept in secret don't get the chance to express their emotions and download that adrenaline. They got to stuff it the American way. Okay? So, when you have all that built up adrenaline, you don't get it out, it can affect how your system works. So the dorsal vagal complex, there's an interesting book out there called the polyvagal theory by a guy named Porges. And there's more parts in the vagus nerve than we give credit for. There's some really ancient parts of the vagus nerve that are demyelinated. And as an example, back to the animal kingdom, if you see a gazelle getting chased by a lion, and right when that lion goes to bite that gazelle, you see on these animal shows, these animals just collapse. And they're like dead. The lion's like, great, I killed that guy. I'm going to go find somebody else. I'm hungry. And then you see this gazelle pop up, and they're like, the clever gazelle gets away by feigning death. Well, it's not clever. It didn't mean to do that. It was a reflex. Their dorsal vagal complex just went on full bore. I'm going to die. The tsunami's about to hit me. And they just collapse. And then they wake up, and they happen to be alive. There's a survival benefit in having this happen because they're not eaten and they can get away. So that's why we have it. The other benefit is if they are eaten, it doesn't hurt so bad. Now imagine if you're a 12-year-old girl and your 180-pound stepfather is on top of you every night, raping you. Okay? She's gonna kick in with her dorsal vagal complex. And this is probably where repressed memories happen, is because people just go away when they're in these horrible traumatic events. They're not there. And this stuff can pop up later. So I'm gonna skip body memory. I'm gonna briefly talk about trauma treatment and then finish up here. So they did one study I found interesting where they treated people, they had about 500 people with chronic depression. About 300 of them had childhood trauma, 180 did not. And if you gave an antidepressant, the people without childhood trauma had better improvement than the people with childhood trauma. If you did psychotherapy, it was the opposite. The people with childhood trauma did much better. And of course, if you did both, everyone did better. So it's just an example that there's a difference between your history of childhood trauma. They're different disease processes in a way. Now, what's EMDR? EMDR is eye movement desensitization reprocessing therapy, where you go to see a specialized therapist and you follow lights with your eyes and you remember traumatic events until they don't bother you as much. They're less distressful. So most of the time I've heard of that, that's hokey. How does that work? But there's some new theories out there that dreams and REM are used to encode memories in your hippocampus. So maybe there's some relationship. But the idea, again, that memories are attached to feelings, images, beliefs, and physiologic responses, somehow, it's like a life hack. If you're remembering something just with one side of your brain, it's pretty painful. But when you use both sides of your brain, when you're looking at these lights, somehow your brain can modify the memory and put a more positive spin on it. And this is an A-rated, strongly recommended treatment by the VA and the Department of Defense. So they did one study, and this is not really a fair study. It's just, but Bessel van der Kolk did a study where they did EMDR versus placebo versus Prozac for PTSD. And the people with childhood trauma, 10% were better after 8 weeks of EMDR with no symptoms. And then 6 months later, 30% had no symptoms. So despite no further treatment, they still got better over time. Same with adult PTSD. After 8 weeks of treatment, 40% of people had no symptoms. 6 months later, 70% were symptom-free with no further treatment. So this eye thing does have a persistent benefit. Prozac, 10% improvement for PTSD. They were asymptomatic after 8 weeks of Prozac. Of course, in the study, they stopped the Prozac. And so 6 months later, no one had any improvement. They all had symptoms. And same with adults. So it's not a really fair comparison, but mindfulness is a great treatment. It's the attention to and awareness of the present moment and non-judgmental acceptance. There's a lot of evidence to support mindfulness in a treatment of people who've had trauma. And I'm running low on time, so I'm going to skip to this one. Yoga as treatment for PTSD. They did a 10-week trial for adjunctive treatment in 64 women who were resistant to regular treatment. And after 10 weeks, half the women had no symptoms of their PTSD with yoga in addition to standard treatment. So now I'm going to critique the DSM a little bit here. And, you know, as a primary care doctor, I used to look at the DSM as like the Bible of psychiatry, and I put a lot of emphasis on it. So, in reading about this, I'm backing away from that. And if you look at the DSM, you know, it really ballooned in 1980. In 1968, there was 182 diagnoses and 134 pages. In 1980, it jumped to 265 diagnoses and 500 pages. And then today, it's 297 diagnoses and almost 1,000 pages. So here are some critiques by people in the mental health world about the DSM. So eminent sociologist Alan Horowitz, who's written many books about the topic, says that the standardized DSM-3 benefited research-oriented psychiatrists, improved reimbursement for clinicians treating psychiatric disease, and that the theory-neutral symptom-based checklist made it so all clinicians could treat mental health disease. Well, there's some good in that. Anyone, all primary care people now could, you know, treat mental health problems because they had access to this checklist. It was empowering. Okay, and that is a good thing, but it also met the needs of the pharmaceutical companies. And also, it sort of changed the way we framed mental health in the country. Because in 1968 with the DSM-2, manic depression was a reaction to external stressors. In DSM-3, it became bipolar disorder, a brain disease. The sort of Cartesian, biomedical model of mental health. So, Thomas Inzel, the National Institute of Mental Health Director, said that the DSM diagnoses are based on consensus about clusters of clinical symptoms, not any objective laboratory measure. In the rest of medicine, this would be the equivalent of creating a diagnostic system based on the nature of chest pain or quality of fever. British Psychological Open Society gave an open letter stating that there were major concerns over the diagnostic thresholds across a range of disorders in the DSM-5, leading to the medicalization of normal experience and the use of potentially unnecessary interventions. Lisa Cosgrove of the Safra Center of Ethics at Harvard did a study in 2012 showing that 70% of people in the DSM-5 task force had financial ties to the pharmaceutical industry. And then there's Dr. Bremis, a child psychiatrist in Alberta, who noted that diagnosis is from the Greek gnostic, relating to knowledge, and are the DSM constructs based on knowledge or categories? They originated from static psychopathological states in adults used for epidemiologic research. So I guess the idea is that maybe anyone can go through multiple types of, pathology states over time in their lifespan. And they don't have permanent brain diseases. So Bessel van der Kolk is an eminent traumatologist, and what he did was he presented the diagnosis of developmental trauma disorder to the DSM-5, and it was rejected. This was going to be to fix the problems with PTSD and to make a more holistic look at everything. And it was felt by the DSM work group to be too broad, and that it would supersede not only PTSD, but all disorders caused by interpersonal trauma and poor rearing. So some people thought it would upset the apple cart, and that's why it was rejected. That the funding of academic research labs that are funded to study particular disorders is one aspect of the apple cart, and the other would be the pharmaceutical industry. So, in models of mental health here, the biomedical model of mental health and addiction is that risk factors exist, but we're not sure what causes it. There's anxiety disease, bipolar 2, addiction, depression, they're brain diseases. And that's what we read a lot in sort of on all these websites. And that often, I would explain, we need to put you on this antidepressant because there's changes in your brain chemicals and your brain structure, likely the causes of this problem, and we want to treat it. We want to get it better. And that these are not normal. And that you need to take this medicine and see a counselor for this condition. It might remit, it might not. Now, the trauma model of mental health is a little bit different, and this would probably be better, in primary care, is that the majority of people suffer traumatic experiences growing up. These affect your beliefs, behaviors, your resilience, and cause emotional dysregulation via a variety of epigenetic, hormonal, brain chemical, cognitive, and psychological factors. You may need medications to start to get better, but in the long run, you need to process your childhood traumas to achieve emotional stability, healthy coping skills, improve self-awareness, and self-care to get emotional recovery from your childhood experiences. This is pretty normal based on what you've experienced. You can get better. It's got a more positive spin to it. So, how do we communicate things, how we populate our problem list? I used to say, oh gosh, this patient has an eating disorder. This patient has a picking disorder. This patient has opiate dependence. I tell them that, either I don't know what's causing it, or, it's, but it's a dopamine problem. But now I look at these patients and I see that these are solutions often to people's problems. They're not the primary problem. How do I communicate this to my patients? Are these diagnoses or ontologic classifications? You have your anxiety disorder, your depression, your chronic fatigue. How do I talk about this to my patients? Often I might be saying things that make them feel quite hopeless, when I discuss what caused this. And these are probably simply symptoms of their underlying trauma. So I'm going to skip these, but there's basically, you take Beck's cognitive triad about people feeling worthless and broken and unlovable, and that no one loves me, and that things will never change. And I put some of my typical, older language about how to describe mental health. And the next slide, I just put some more non-judgmental, non-reductionist language. And I think it's a good way to start thinking about what are your patients thinking about themselves. If I just label you as having a brain disease, I just confirmed that you're broken and confirmed all your sort of internal beliefs about yourself. So you have to be very careful about how we talk about these things. So trauma-informed care looks like this. I think DSM, is a great tool, but it can unwittingly help make us in primary care label our patients and miss the underlying trauma that they have that might be the main issue. Labeling patients can feed hopelessness and reinforces negative self-image for them as bad and broken. Medicalization of a patient's symptoms make it more difficult for them to put their symptoms in a coherent, biographical narrative. They can't put this in a narrative in their life. It's confusing and they get lost. Asking a patient about their childhood is sending a powerful message that you care. You're not saying what's wrong with you, you're saying what happened to you. These conversations, if handled well, build trust between you and the patient. Now read attachment here. Here's where people that had attachment issues when they're young, they need to attach their medical provider to be successful. So more trusting relationships help us identify active abuse when it's happening, active interpersonal violence. They're more likely to come forward and be honest. They're more likely to follow your suggestions. And we need to, educate patients in the doctor's office that unconditional self-love and acceptance is important for your health. It's not just something you're going to find in the self-help section. So in Kaiser, what they did, Dr. Flitty's practice, they started sending screenings home about childhood trauma in the physical that went home and did the review of systems and any changes in your health. And when people came in and answered the questions about childhood traumas or other wartime experiences, the doctors and Kaiser simply said, how did that affect you later in life? So they went back and looked at the year before to the year after doing that. And they noticed that there was a 35% reduction in doctor's visits, 11% reduction in emergency room visits, and a 3% reduction in hospitalizations. So, it's not a definitive study, but it's pretty, interesting, provocative. So the 4 R's of trauma-informed care are: realize the prevalence of traumatic events and the widespread impact of trauma, recognize signs and symptoms of trauma, respond by integrating knowledge about trauma into policies, procedures, and practices, and seek to actively resist re-traumatization. Who are these trauma patients? They're the angry ones. They miss appointments. They can present in crisis. They can have poor self-care, pain issues. They frequently have all these diagnoses: fibromyalgia, IBS, chronic fatigue, depression, ADD, addiction. How do we bring it up? Many trauma survivors do not seek mental health services. They look for help in primary care settings presenting with physical symptoms. Neither provider or patient will be aware that current physical complaints may be connected to past traumas. Research suggests that most patients with a trauma history do not object to being asked about their trauma history in a primary care setting, but will not typically disclose anything unless asked directly in a safe, supportive manner. Do not ask for details, ask about generalities, and you can simply stating that a patient's mental health issues are related and somatic symptoms might be related to childhood trauma can be incredibly healing for some people. But when you do bring these things up, just be ready to detect a bad reaction and slow down and say, how are you? And make sure they feel safe. So ways we re-traumatize patients are with invasive procedures, removal of clothing, physical touch, power dynamics of relationship, vulnerable physical positions, loss and lack of privacy. I had a patient the other day, brand new patient, healthy, and we were reviewing healthcare maintenance, and I offered her breast cancer screening, and she refused. And I was like, okay, and I was moving on, and then a whole change came over this woman. She started looking down at the ground. She couldn't look me in the eye. She kind of went in on herself. And I was like, what just happened? And she just went into her childhood shame self because she said no to a doctor. I don't want breast cancer screening. And so I was like, are you okay? I go, don't worry about saying no to me. This is a judgment-free zone. You're in charge of your body. And kind of worked with her a little bit and got her back up, but she totally fell into a shame pit. And obviously when she was younger, she, some stuff happened where she did not feel safe saying no to another adult. So next steps for any primary care clinic that you can consider. And again, this is a talk meant to sort of generate thought and for people to look at things differently. Advocate for trauma-informed training for all your staff. Develop screening for all patients for PTSD and adverse childhood experiences. Create book, app, website lists to give patients interested in learning more. Develop simple trauma-informed psychoeducation materials we can give to our patients. Advocate for community support groups for PTSD, substance abuse using proven programs like Seeking Safety. Develop, improve referral relationships with community resources. Get more support and education for providers around crucial conversations. Get buy-in of trauma-informed care. Because patients will believe it if it's coming from doctors, and they'll better engage with referrals. Improve relationships with local therapists and understand what trauma services are available in our community. Make our waiting rooms and exam rooms more welcoming with positive messages in our exam rooms. take steps to prevent secondary traumatization in patients and providers and caregiver burnout. What is physician burnout if not just sort of some PTSD from working too hard and not taking care of yourself? Advocate for being a trauma-informed organization in your system. So again, remember Descartes here. If you're seeing your patient and getting ready to label them with something, I want you to remember, I want you to go with the Freudian way, not the Cartesian way. And so, so don't put Descartes in front of the horse. Okay. There's a lot of references in back if you guys want to read any of the stuff I read. Yes, questions?
Tony, I noticed on the medical diseases that were studied in the ACE study, almost all of them were behavioral, but I didn't see chronic pain. And so half the people that walk into my office, I think, are childhood trauma-related chronic pain and not.
You're right. There's a lot of, and I didn't find an easy slide from Dr. Anda about chronic pain in his slide deck. But there are a lot of studies to suggest that chronic pain is related to childhood trauma, and that there is a relationship. And there's also some studies to suggest that there is an autoimmune connection, and that stress can cause autoimmune dysregulation and lead to at least increased risk for autoimmune disease. But the ACE study in particular did not study that, but there's been over the last 20 years, many other studies that have come out and showed a relationship. Definitely. Yes?
Just wanted to put out a plug for Bridget Collins as a local provider of very important services for this community. There's actually a fundraiser this weekend. I think that there's still some spots available at the table for the family medicine table that was purchased. So if anyone's interested, I think Jessica Bloom is still a person to talk to about that.
Great.
One thing to keep in mind is the prevention of this cycle. I really appreciated that pointing out the epigenetic and generational things, and the response. A lot of times people are thinking we even put resources into children, or we take it away from adults who are beyond repair and focus just on kids. And it's really important in our policies that we see that kids grow up in a context. You help the adults, you stop breaking this ongoing cycle. So when you're finding yourself in those kinds of policy arguments, or where do we put our resources, it's not either or, it's both and. These are about systems, not about linear paths of individuals, their individual life courses. These are all networked.
I totally agree. And Bridget Collins has a lot of great parenting programs, parent mommy programs, and I do actually, in some of my patients, I encourage them, hey, studies show that if you get better, your child will do better. And that is a good way, I think, to encourage people to get involved in taking care of themselves. Done.
Deeply thank you for this. I think this has been a great presentation to generate more conversation about this. And, a lot of focus is, about childhood trauma and how it leads to addictive personalities, depression, anxiety, symptoms, and this and that. But I think this is something that we probably encounter every single day, with our patients when it comes to compliance with medical care. And, multiple times a day, people are struggling with taking their medicines or making dietary changes or doing exercise like they should. And I found it so helpful to say, why do you think that is? And it almost always stimulates a conversation about, whether or not they feel like they have the time or that they are important enough to put the time into their health. A lot of times, people are overextended and they have a hard time putting themselves first. And it just all stems back from issues that they have felt over childhood or just different things. And so I think we can impact people so much by even just starting the kernels of this conversation. regarding compliance, and then it follows over in patient safety.
Mhm. Question or statement or comment?
Yeah, mine was.
Yes, you.
Tony, thank you so much. This was outstanding. One thing from a boots on the ground perspective that I really appreciated was when you provided a narrative, because I really think that's where the experience starts. I'm a physical therapist, so, you know, I have less responsibility, and less authority from the doctor perspective, but creating that safe and comfortable environment starts with that narrative. What resources would you say would be helpful on just how to create a safe and comfortable environment for, in a situation with receiving informed consent for physical therapy treatment, if there's a delayed verbal response or delayed cognitive kind of response, when you're working with public health, for example, we want to create a safe and comfortable environment, but, you know, that's where I'm interested in how we can be helpful out.
Well, I mean, there's a lot of, with the substance abuse and mental health, SAMHSA, they have a lot of information on trauma-informed practices, which would be helpful to anybody. And really, there's trauma-informed schooling, there's trauma-informed healthcare, there's sort of trauma-informed, you know, business practices. You know, there's so many different ways you can apply it, and there's a lot of online, and I always just recommend understanding your patients, and I recommend everyone go read Facing Codependence by Pia Melody, and another book called Flight from Intimacy by Janae Weinhold, that kind of just nails down some big behavior patterns and gives you sort of an idea, because I think what happened is that with the DSM-3, primary care said, hey, we can start treating mental health problems. We can do behavioral health, but they only took responsibility for the psychopharmacology treatment. You know, we only took responsibility for prescribing the medicines. We never took the responsibility as primary care to step up and go, and I'm going to learn how the behavior is with my patients and do best practices on influencing people. You know, we never learned that. We just learned about prescribing. And I think that was the big thing. So if you can learn about how your patients behave and get it, then you can actually sort of see when you've offended them, see when you've scared them, you know, talk about traumas non-judgmentally, and then make them feel safe. And I have patients now feel safe, like, you're making me feel uncomfortable. I'm like, thanks for letting me know, you know, and I can step back rather than not be afraid to bring it up. And, you know, so, and that's kind of where we want to go in our communication, I think, with our patients. Thanks, Elizabeth. And I can stay for any questions afterwards, or I want to chat. So I'll let y'all go.